So good morning, everybody. It's finally spring. I don't have to get up at 6 in the morning and put on 17 layers of clothes to get here early. So it's a great pleasure this morning to introduce one of the people responsible for getting me where I am, Ivey Boufford. Maybe her greatest achievement was being able to put up with both Red Schiller and myself as residents. Joe is, I mean, this could be like 8 pages long in terms of all of the incredible things she's done, but she's now Professor Emeritus of Public Service Health Policy Management at the Wagner School. She is president of the New York Academy of Medicine, which many of you visited just last week for our research symposium, which was incredible. She's co-director of the National Program Office for the Robert Wood Johnson Foundation Health and Society Scholars Program. Formerly, she was dean of the Wagner Graduate School of Public Service at NYU. She served as Principal Deputy Assistant Secretary for Health. She served as the U.S. representative on the executive board of the World Health Organization, and she's board certified in pediatrics, and was also president of what's now known as Health Plus Hospitals. Don't ask me why, but at the time was Health and Hospitals Corporation, and it's had so many important roles. But most recently, I've had the pleasure of working with Jo in her work on population health, because she is one of the earliest people. I mean, we remember as residents her talking about the role of physicians, not just as people who sit in their offices and wait for patients to come in, but as people who have responsibility for the health of the communities in which they practice. I mean, for some of us, all of this talk about population health is not new. It's the stuff that we grew up with in residency, and that was largely based on Jo's influence and the creative things that she was doing all the way back, and I won't say when. So it's a great pleasure to introduce Ivey Boufford.
Good morning, everyone. Good morning. You awake? Yes. Okay, good. Thank you. Got to check at this hour anyway. It's very nice for me to be here. It's really exciting to be giving grand rounds in this department, especially one that's, I think, really centered around such cutting-edge primary care practice, and with the leadership of Neil Kalman. I won't go into that either. He's always been the same ever since he was a resident. He's provocative and shakes things up, and has done amazing work. And I think linked to Mount Sinai, I want to acknowledge a really strong history here of community medicine and family medicine with Kurt Duschel and others going way back. I think I find this society gets increasingly ahistorical, and we sort of reinvent the wheel all the time. So it's important to acknowledge some of our forebears. I have always, as Neil mentioned, been a strong advocate for primary care, because I think primary care providers are really on the front lines of communities. You are, in fact, the physicians, nurses, social workers, and others that really understand and live, in some instances, what's going on in communities much more than many of your colleagues that are bound to the hospitals for their work. I did practice general peds for 15 years. I will give dates. I was a resident in social medicine working at the Martin Luther King Health Center in 1971 to 1974 when the South Bronx was burning. And one little side story, when I interviewed for my residency at Montefiore, you interviewed there first and then took a cab down to MLK to interview with the health team there to be accepted. And the cab driver asked me on the way down, he said, well, why are you going down here? This was 164th and 3rd Avenue in 1971. And I was fresh from Ann Arbor, Michigan. And I said, well, I'm interviewing down at the health center. He said, what's the matter? Aren't you good enough to work up at the hospital? So that was, he slowed down to 2 miles an hour, I think, to let me out. But I think that it's kind of indicative in some ways of the fact that there has not, and still isn't, in my view, has not been significant historical emphasis on primary care. It's gotten us into some of the dilemmas that we're facing now in health policy in terms of the need to begin to move people out of hospital, prevent unnecessary admissions, and the workforce is a problem. So there was a bit of a golden age, I think, and maybe it's coming back again. I think between in the sort of mid-60s to 80s, and community health centers were sort of at their peak, and many of the models that we're working to recreate now were in full force. Many of us trained with them, which made us very happy. I think we realized, certainly I did very early on, that you can take care of patients, but if you're sending them back out into the same conditions that they came in from, they don't have the option often to make the healthy choices that you're exhorting them to make, or to avoid the negative impacts on their health that are really in their community. So now I think we're, at the time we didn't really have the evidence base for that. You sort of knew it intuitively. And you'd look at the rankings of the community boards and they'd say, you know, number 8 was maybe healthcare, number 1 was a job, number 2 was housing, number 3 was security in the day. And it was always disturbing if you're trying to do health policy, because where are we here? We're not really one of the priority areas. But I think we now have an evidence base to operate much more aggressively in this space, and the real opportunity. And I want to talk about that a little bit today. Let me just make one word advertisement for the New York Academy of Medicine. We are right next door, and we are dedicated to the health and well-being of people living in cities. We do this through our Institute for Urban Health, which is where our policy work, our education, our research, and our program engagement takes place. We have really become very involved in East Harlem over the last 7 or 8 years. We never really opened the doors in the past, so that's been a really interesting and important experience for us. We have a world-class history of medicine and public health library. If any of you did not know that, you should go and visit it immediately. It's open to the public by appointment, and is a really exciting way to look back at the past and inform the future. And finally, we have over 2,000 fellows, members, and students and residents who are part of our group, increasingly interdisciplinary. So I encourage you to take advantage of that. Come and visit us. We have an event coming up on April 24th with Paul Francis, whose name will come up during my presentation. He'll be presenting on Albany Update on Monday the 24th, so I encourage you to come. So let me talk a little bit about what's going on in the state in population health. And the Academy has been very involved with the New York State Health Department, especially, and also the New York City Health Department over some time because of our priority on prevention and health disparities. And we did begin Age-Friendly New York City initiative in 2008, and it has been one of the most rewarding activities that we've been involved in because it really meshes very well with this idea of health in all policies. If you can make a city hospitable and communities safe for older people, you make them safe and hospitable and health producing for everybody. So they kind of travel together. And I think we finally have an opportunity at the state level to move that along. So let me start by looking at the issue of health status. So this is what may be a fairly familiar diagram to some of you. Where does the US stand among rich nations in terms of our health outcome? This worked earlier, oh well. Right hand, far right in the red circle is where the US is. We spend more per capita in the health sector than any other country in the world, almost twice as much really. And our life expectancy, which is the vertical, is not what you would expect in terms of, if you will, return on investment using an economic model. And the US lags behind the OECD countries, which are the high-income countries. We are 30th out of 34 in infant mortality, 25th out of 34 in maternal mortality, 26th out of 34 in life expectancy. And so people have begun, and this data has become more visible. You can see this is 2010, 2011, the last really 5 years, with policymakers really asking those questions. And many people say, well, that's because we're a very diverse country. We have really big health disparities, especially in poor communities and communities of color. And those must be unacceptable, and all of you I know are working to ameliorate that. But it actually isn't the fact. If you control for race and income, you can see that up until the age of 75, the evidence shows that the mortality ranking of U.S. non-Hispanic whites is no better than 15 out of 17 of the peer countries. And those of you that read the newspaper may have seen the second cycle of reports from someone named Angus Deaton, who is a researcher who is doing work on the shortened life expectancy of white males, which in the U.S. is now where Russia was about 10 years ago. It's moving down into the late 50s. A lot of it believed to be secondary to stress, alcoholism, and lack of social mobility. The American dream seems to be falling away in certain groups of individuals. So then we sort of ask ourselves, well, why is this the case? And then you begin to see this is the sort of expenditure. You can see the flag on the left. And the countries are a little bit clearer than in the other diagram. I think Japan does best, has the highest life expectancy with the lowest investment. So this is really how health improvements are made. This is a pretty iconic diagram from British researchers, which really says you're born with a certain set of characteristics. We can modify those a little bit, probably not as much as we may be able to do in coming years, but at that point, you're in a family structure, you're surrounded by situations in your community, and then you live in a society that has policies around the outside that help create environments that are more health producing or not. And if you want to get movement towards health, you've really got to align activities in all of these areas, and that's part of the trick. So you can operate locally, and you need to, but you also need to influence the policy world to make it easier. So in looking at these multiple variables, it became apparent, and I think was reflected in a 2003 report of the Institute of Medicine, now the National Academies of Medicine. You have to work with a lot of people. So in the old days, you'd think that the government public health agencies were really responsible for creating health conditions in communities. It became clear that they could not do it alone in this governmental, you see that on the side, and had to partner with CBOs, with academia, with other government entities, certainly the healthcare system, business unions, the media. This was a big change for public health thinking. So they, in effect, I think we often forget that the public health community is coming out of a kind of we do this way in the same way that a lot of clinicians are. So we have to kind of bring people together in a conversation. The one bubble I want to draw your attention to are these community-based health and human service agencies. Now, when this paradigm was created, they were not particularly emphasized, but due to recent research by Betsy Bradley, who's now the president of Vassar and was at Yale doing this work, she's identified a really important factor that seems to be correlated with at least life expectancy and the broader health indices, which is the ratio between investment in social services and support services and health services. So in her research, and again, in the richest countries in the world, the countries with higher ratios of social to health spending have statistically better health outcomes, lower infant mortality, less premature death, longer life expectancy. So while in the United States, we spend, for every dollar on healthcare, we spend about 90 cents on social services. In the other OECD countries, they spend $2 on social services for every dollar on healthcare. So what are we talking about with these social services? These are the buckets that she's been looking at and trying to analyze through national economic accounts. And I think increasingly the evidence base is such on many of these activities, and I'm sure I know you all are working on those with your own patients, has been recognized by CMMI, and they put out a request for applications in the fall calling for what they termed experiments to look at the inclusion of social determinants of health in pilots around caregiving. And recently, Columbia was awarded, I think, $130 million for an accountable care community. This idea is to really integrate and coordinate these services in a way that they have not been coordinated, probably outside of primary care settings for quite some time. Now, I want to flag the use of the term social determinants of health, because if you're coming at this from a broader population health perspective, to me, this would be integrating health and social services around the needs of an individual patient, not necessarily changing the conditions in communities. I'm going to come back to that as we go forward, but I think it's an example of how terminology can get in the way of really good dialogue, because it's not a competition, but you need both, and you need to articulate both. So increasingly, the evidence base is such that, I hate this, sorry, I always think it's gone when these bubbles come out, but it ever is. Increasingly, the evidence base has expanded. So now we're beyond the traditional public health system into really thinking and understanding better how issues in other sectors really affect health. So we have pretty good evidence, increasingly in the US, very strong evidence in Europe about the importance of economic development, of built environment, of urban planning, of social supports, of transportation, education, many of the things that you are probably familiar with. And what's beginning to happen, especially in urban environments, which is particularly exciting because you have a mayor in charge of these agencies and the community or the population is sort of in the face of elected officials. It's a really nice governance level to try to take on some of these things. And we've seen this in New York with bike paths and pedestrian walkways and malls trying to reduce emissions from cars. And obviously decontaminating housing for patients with asthma. I'm beginning to see these strategies that are contributing to action in this broader area. And this awareness has kind of led to this statement about your zip code may be more important than your genetic code in terms of your life expectancy. Place becomes really important, and these factors are very important to influence. So this has led to a term called health in all policies approach, which really means we begin to look at decisions that may be made in a sector like transportation. So for example, a really interesting international example, $3.1 billion from the International Monetary Fund. Karachi, Pakistan builds ring roads and flyovers. Bogota, Colombia creates a pro-poor transportation policy, which uses gondolas to bring people down to the bus stop. They co-opt the jitney drivers to own the buses and create a pathway into Bogota for people from those communities using the bus and also bike lanes and pedestrian walkways. Very different strategy, same amount of money. Obviously, the car factor has huge implications for health in terms of pollution, road traffic accidents, et cetera, and exercise. Obviously, if you can't walk on the highway, it's pretty hard. So elements of this is really a recognition, and to the degree this is recognized as an important approach, that you've got to have health and well-being. I think one of the things, if you think of health as medical care, the tendency is to think of health as a giant sucking sound. All it's doing is costing us a lot of money and driving money out of the education sector, out of social services. It's going to collapse and kill us all. But in reality, health is an input into economic and social development and an output. So it's very important to remember those distinctions because you cannot have a productive workforce if they're not well. You don't have active civic engagement if people are dealing with other concerns and not able to be actively involved. Third bullet, all government policies can have an impact. Again, we didn't have this evidence base 10, 15 years ago. We have a very convincing evidence base now. And the need for collaboration across the public and private sector and across agencies to really have this work. So with this in hand and this approach in hand, New York State has taken this up and really quite recently. And there has been the governor's State of the State message in January called for health across all policies in New York State and to make New York State the first age-friendly state using the World Health Organization model of age-friendly. And I'm not going to talk much more about age-friendly. I would if I were giving this talk to a geriatric group of folks, people that are not older people, that too, but people that are focusing on the needs of older people. But I'm going to try to make it a little bit simpler. Yeah, all of us, right? A little bit simpler. The rationale is reflected in these bullets, and Paul Francis, who's Deputy Secretary of Health and Human Services, to Governor Cuomo, convened a group of agencies. There were 13 agencies there, all agency heads. I was able to attend that meeting because I'm the chair of the Public Health Committee of the State Public Health and Health Planning Council in my proto-public role. Otherwise, it was all state agencies. And he convened the agencies and really laid out the rationale for why New York State is taking this up, why the governor's called for this. Obviously, substantial resources in healthcare reform, and I think the feeling that there is progress in elements of the holistic healthcare reform, including the prevention agenda, which I'll talk about in a minute. New York has moved from the 25th healthiest state in 2008 to the 13th healthiest state in 2015, and New Yorkers are very competitive, so we want to get up there and we want to be the healthiest state. That's a good thing that somebody wants to do that. And then the other thing he mentioned is that we really need to incorporate these health considerations into overall policy decisions by agencies across the state because the evidence is out that that is really important. There's also an economic argument for prevention and attention to population health, and this may be one of the most important ones. In a series of literature reviews, a lot of this work done by Trust for America's Health, if you are following this area and you don't have tfah.org on your phone, you should. They have the most amazing weekly bulletin about what's going on in the Congress around public health issues, have been very effective in their advocacy over the years. This really shows through work by the Urban Institute, and actually the Academy did the systematic review of the literature, that there are proven interventions for tobacco, exercise, and diet that are the core risk factors in most chronic diseases that cost about $10 per person per year. And had New York embarked on those over a period of 2 years ago or 5 years ago, there would have been a net savings of up to $1.35 billion in 5 years. Now, this sometimes comes as a shock to policymakers because the rap on prevention is, oh yeah, it's a really good thing, but it takes a generation, you know, nobody will live to see it. When it happens in 5 years, it's a term of office of a governor or a mayor, especially the usual 2 terms. It's also within the term of office of a senator. This makes a difference. It can happen on your watch. I mean, you have an opportunity on your watch to really do something about this as a political leader. And although it takes a bit of courage, I do want to congratulate Governor Cuomo for taking this on. Obviously, he would intend to be running for governor again on another term in the fall, or a year from the fall. So getting this underway, I mean, those of us who've been in the policy world, you always want to get your phrase or your term in the President's State of the Union message or the Governor's State of the State, but it can also sit there along with 5,000 other words, and the issue is, okay, how do you pull it out and do something about it? And to his credit, they have convened these agencies. And the other thing that was mentioned in the message is that the New York State Public Health Council, especially the Ad Hoc Leadership Group, which I chair, will be part of the implementation process of this initiative. So this is what the New York State Public Health and Health Planning Council is. Historically, it was a place where hospitals got their certificates of need, where community health centers are established or changed, where long-term care facilities are established. It also has always had this role of advising the commissioner on the preservation and improvement of public health. And this was because of a merger of 2 councils in the first year of the Cuomo administration. And so how does this work? It has a committee on public health, which is charged to focus on statewide governmental action and also to promote the kinds of collaborations that underpin the health in all approach. So we have a mechanism for moving this ahead. We've had the initial meeting, and I'll come back to next steps in a minute. So let me spend a little bit of time on the prevention agenda, which is one of the elements of the state reform that has been underway for about 8 years now, 8 or 9 years. This is the goal of it is improving health status of all New Yorkers and eliminating health disparities. It is a call to action because it uses the state's authority for assuring community benefit by requiring hospitals to submit Community need to conduct community needs assessments and commit community plans every 3 years, and local health departments need to do the same thing. They used to have to do it every 2 years. Now, over 2 cycles of the prevention agenda, they use the same community needs assessment, usually done by the local health department, and they are to work as a partnership in submitting a combined plan for their local community. And this means that the partnerships at local level are anchored by the hospital and by the local health directors, but they bring other stakeholders in to that process. And we know a lot more about this because it's been underway for some time. So where does this fit into the overall healthcare reform? This is the famous diagram of the different elements of the healthcare reform. I will not review all of them, do not panic. But one of the things that's important is look in the middle, and you see the word improve population health. This is the triple aim. I mean, it's cost, quality, and improving health. But it sometimes gets disappeared into other language like patient experience or other kinds of activities. So the word is there in the middle. The upper left-hand corner is the prevention agenda. I'm going to come back to that. The lower left-hand corner is where the action is. That's DSRIP. And you'll see that the bottom item under DSRIP says promote population health. This is not a requirement of DSRIP. It is domain 4 for those of you that follow that activity, but it is reported. And the upper right-hand corner is advanced primary care. That's part of, this is all part of the waiver, the development of that aspect of the state's needs. You notice, again, promote population health, third bullet from the bottom. And then on the right-hand side is essentially the revitalization of the former New York State regional health planning mechanism to try to bring the healthcare delivery system and public health officials together. The New York City Health Department runs that. The Academy and the United Hospital Fund are core partners, and there are 11 of those around the state in different parts of the state. So here again, that word population health didn't appear by accident. It's taken about 4 years to get it into that slide. This sounds like, why would you spend time doing that? This is the slide that the Deputy Secretary uses. This is the slide that Jason Helgerson uses. This is the slide. So the audience that you can't get to sees the words. Now, what do the words mean? I mentioned social determinants earlier, and now I'm going to talk about population health. What does it mean? So here's an interesting slide. If you think about this, is work that Steve Teutsch has done, who's a terrific researcher out in California, and really looking at this issue of total population health, which is what we're talking, and we talk about in geographic communities if we're really worried about what's going on in a community in which our patients live. Within that geographic community, we have subpopulations. So we have the clinical care system, which has attributed patients, its panel, the health plans have their beneficiaries, their subscribers. We have subpopulations in public health. Public health has VD clinics, TB clinics, other freestanding, HIV/AIDS, still other freestanding programs for the populations they serve. And then depending on the stakeholders and systems, we have populations, we manage the populations of population health for our diabetics, our hypertensives, our individuals that are subpopulations within the clinical community. So when we use the term population health, it means different things in those different boxes. And it's really important to realize that we need all of them to be aligned in order to get this sort of total population health that we're talking about. So why did the state want to take this on? This is the main reason, is a recognition that almost 45% of the premature deaths in New York State are preventable because the core risk factors for cardiovascular disease, some cancers, COPD, obviously obesity, are linked to tobacco, exercise, and diet. This is not new news to you. But this led to a feeling, and I think underpins the work of the Health in All approach. So we've been, with the prevention agenda, focusing a lot on what that traditional set of actors in the public health community can do, and now have the opportunity to add others. So the prevention agenda has been steered by an ad hoc leadership group. It has lots of members. These are some of the logos, ranging from professional associations, the Medical Society of New York State, all the way to the New York Business Council and everything in between. This group has been advising both the accreditation process for the state of New York, which is one of the first big states to be accredited by the voluntary national accreditation process, and has really shaped the prevention agenda priorities for the state over the last 7 or 8 years. The group is now, Chicanes has been a member since the beginning, and the group is now, the family physicians have been there as well, and the New York State nurses are there now. So as a consequence of this process, we have created these, this is the cycle that's going on now, 2013 to 2015, or 2015 to 2018, are continuation of the previous 5 years of focus on these areas. Now, these areas are very upstream. This is all the work of the prevention agenda is before you get to the doorstep of the healthcare provider. So the plans that are being created through these hospital and community partnerships with multiple stakeholders around the state are addressing an evidence base for these interventions, which include preventive services and getting people access to preventive services, but we're not inside the healthcare facility in this regard. So they're really focusing on either self-management issues or environmental change issues in these local initiatives. And the results of the plans are submitted to the state and are tracked by the state using health indicators, using the basic evidence base from CDC, from the U.S. Preventive Services Task Force and others. A set of interventions have been defined for the various stakeholders, and all of that is available on the state health department website. And this is what came out of the first round of planning processes. So you see chronic disease was chosen, preventing chronic disease, largely cardiovascular disease, by virtually every county in the state. Mental health and substance abuse was the second most frequently selected. And I want to go back to, let me go back to this list because I want to point out that, remember, the mental health and substance abuse were the most commonly selected issues in, second most commonly selected in communities. It wasn't on the original list. Why? Because the state health department doesn't control mental health and substance abuse. They're separate departments at the state. And the Ad Hoc leadership group put them on. They said, how can you do a state health plan and not deal with the issue of mental health and substance abuse? And to their credit, the commissioner went to the Commissioner of Mental Health and OASIS and said, would you join this process? And they did. So there have been 3 agencies collaborating in that more traditional public health mode for the last several years. And the interesting thing has been there is pass-through infrastructure in the mental health world and in the substance abuse world that goes down into communities around the state of New York. Many times those people had never met each other. They had never met the local health director. They had never met the local hospital director. So bringing them into these stakeholder groups has been really an important opportunity. This is the dashboard that's managed by the State Health Department. I'm not going to go into it, but I think you can see it's very robust. The local health directors report on 51 indices twice a year, and they are then reviewed by the Ad Hoc leadership group. So what's the importance of the prevention agenda? I think that it has brought to the attention of policymakers and many individuals in communities the underlying causes of disease, that you have to deal with those determinants of health, and in addition to having a high quality healthcare system. It has been used because it shows up in all those boxes I showed you. It has been increasingly used to align work in the different elements of the healthcare reform, and it's created a platform really at community level for stakeholders to come together, and organizations in state government as well as others who have resources to think about local community priorities. Each community has to identify 2 prevention agenda goals they're going to work on and 1 health disparity that they're going to take on. So let me give you an example of how. This is an example, it's a great example that comes out of Schenectady. Ellis Hospital is a major teaching hospital in Schenectady, and they analyzed this is the elephant image they put in there because it was an example of everybody in this stakeholder platform in Schenectady having their hand on a different part of the elephant. And so the executive director presented the fact that they had realized their costliest patients were people in end-stage renal disease. These were what they called the million-dollar patients, and they looked at them more carefully. They also realized that the average cost of their affiliated ACO for end-stage renal disease was $70,000, which is about 9 times the state average, and that a very significant percentage of their ESRD patients were suffering from diabetes. So they had a conversation with the local health director, public health director, who looked at their data and comparatively and realized that could show them that the incidence of diabetes was highest. It was 65%, in Schenectady, was 65% higher than the rest of the state. And then they could also map the communities in which that rate of diabetes was higher. So all of a sudden we have the basis for a conversation and a partnership. Okay, I got a problem with the cost of care. Is there a way to intervene earlier? They then partnered with the Cornell Extension Service, who did surveys of about 2,500 residents of Schenectady, including oversampling some of the communities in which the highest incidence of these problems were identified. And they asked questions about obesity, and they asked questions about food insecurity. And what they found is the patients who were the most food insecure in the last month were obese. So the relationship, it's a kind of counterintuitive relationship perhaps, but I think they had, in New York, in Schenectady, they had 18% of people with a BMI over 35 ran out of food sometime during the previous month. 30% ran out sometimes and not monthly, and 39% experienced it every other month. Every 2 months they had food insecurity. This was really stunning to all of these people, actually, and it would only have come out in this kind of conversation. So they created a food insecurity work group, and with community members using the Prevention Agenda platform, and developed an initiative that deals with setting up 8 food pantries, using marketing principles so they look like grocery stores, people can use their SNAP benefits, advertising it, trying to create financial incentives with the city government so that green carts can be licensed and come into a public space with a fair every Saturday, but a set of solutions which are not particularly unusual to us in that sense, but were not previously the case in Schenectady. And then the other issue that's not become as visible as it should, but I want to put this diagram up because it leads into a later conversation. This is work by Larry Green, who repeated in 2001 a sort of iconic study by Kerr White looking at the National Medical Ambulatory Care Survey and the UK National Health Service data registry. They looked at 1,000 adults, I'll use Larry's, 1,000 adults over 21, asked them, looked at how many of them had felt ill in the past year. 800 answered they had. 327 actually entered the formal healthcare system. So this difference between 800 and 327 is people self-care. They go to the pharmacy, they go to the Botanica, they go to wherever they go, to the smart person in their family to manage their illness. And of those who enter the healthcare system, you can see dominantly they go into primary care or hospital-based outpatient care. Less than 5% are hospitalized at all, and less than 1% go into a teaching hospital. Now, this is a diagram and a really interesting study that I think Paul Francis saw for the first time about a year ago and just completely freaked out. And the point is that we, as a country, are disproportionately invested in what is arguably the best specialty medical complex in the world, and also biomedical research. But we're not investing in these social services, we're not investing in primary care. And just as an example, this is back to that diagram again. Upper left-hand corner, prevention agenda, there has been no new state money invested in the prevention agenda. Everything that's been done has been done through grants from foundations. Lower left-hand corner, $8.25 billion to restructure the hospital systems and healthcare systems, $100 million in the waiver charged for creating advanced primary care, not any meaningful, I guess 10%, depending on the ACA or what happens, meaningful reimbursement increases. And the governor appropriated $13 million over 2 years, which was recently renewed to keep these regional planning activities going. So this is the reality we're still in, and I think the question is, can that be changed? Some of the strategies that are being used are to really begin to look at other sources of funding, which is one of the reasons why these other agencies' involvement is potentially quite interesting. Community benefit. This is a requirement that hospitals have to report their sort of investments in community benefit, largely disproportionate share, largely uninsured patients. Graduate medical education in New York State is a big one. We've been looking at two categories of community benefit, which are called community health improvement and community building, which are defined very much in the way that the prevention agenda is defined, and looking at the alignment of hospital reporting to the IRS with their statements of what they're going to do in DSRIP 4, with their community statements within their prevention agenda groups. And we've just finished, the Academy's just finished an analysis of that alignment in 2013, which is the last time the data is available to, and sent it out to hospitals and to local health directors to start a conversation. There's no good or bad, it's the reality, it's a baseline number, and the goal is to begin to move what is $280 million in only two categories of the Schedule H in 2013. Now we know it's over 300 million in 2014. This is a rounding error in DSRIP when you're looking at $8.2 billion. It's a lot of money in public health when you're looking at going from zero to something. And similarly in primary care. So part of the goal is really looking at that. Regional economic development councils are another priority of the governors. There's $300 million allocated around the state every year to groups who then decide how they will make local investments to advance economic development agendas. We have been tracking the health investments in those plans over the last couple of years. They've actually gone up from about 8% of the projects are what we would call positive health impact to about 15%, and the opportunity now is to increase the attention to the spending of those councils with that money. Banks and community development corporations have legal responsibility through the Federal Reserve to invest in communities. Many of them, it's a business model. It's not really largely social giving. It's really looking at return on investment. So they'll build a community health center because there's a Medicaid stream of income, but a lot more activity in that area. Social impact bonds is another animal. So the idea is sort of looking at these other vehicles for bringing money into the system and moving forward on these health across all policies. So I mentioned that that Paul Francis has convened this group. The idea is that within 2 months, they are supposed to look at their programs. What are they doing now that could have a positive or negative health impact? And they're supposed to record that. And what are they planning to do? Programs and capital investments, regulations, contracting that they're planning to do over the next 3 to 5 years. And how would they do it differently if they thought about the health impact or if they thought about the impact on older people, because this is the age-friendly part of it. Trying to make it easier. This was a strategy we had used in the city when we did age-friendly New York City, because the last thing people in government want to do is have you take their money away, give it to somebody else, make them spend it on something they weren't planning to spend it on. So this is all what we call low-cost or no-cost interventions. What are you going to do anyway, and how might you do it differently? The health department and the NYSOFA, which is the Office for Aging, will provide technical assistance once those reports come in. Paul Francis will be convening the agencies every 2 months to review them, and then that will sort of steer state-level engagement in the policy work, and then the local level participation for those agencies that have infrastructure in the communities will be played out as they join the prevention agenda platforms in their local community. So you have the opportunities to deal with the people who manage housing, the people who decide transportation policy. Certainly the area offices on aging are raring to go, but the people involved in this Department of State runs the Regional Economic Development Council process. They run economic development intervention for the city, and their person there is absolutely completely fired up about this. He's already going to change the language in the RFA to deal with health impact and age-friendly. And then these other things that this is what we've really learned about this process as we watch it go forward from age-friendly. The point I want to make here, this is in the health structure. We've got to watch language. We need to work with hospitals. We need to show that these people have to really engage together, and these local platforms have to be built and supported. And on the advancing health across all, this is sort of what we've learned from our work with age-friendly in New York State the last 8 or 9 years is changing the environment is more effective than changing personal behavior, and that's really where it gets to the broader determinants of health. We've got to look at low-cost, no-cost interventions in order to make changes that we need. The political support I've talked about, and engaging the public and other partners. One of the mantras in the age-friendly work is that older people are the experts on their own lives. And when you think about that, they have to be engaged in driving these interventions and other activities. Well, the next steps for the process that Paul is chairing is that, I think I mentioned he will be convening these groups every 2 months. They will join the Ad Hoc leadership group, some of the ones that have tentacles into the communities, and we will move forward from there in a public forum. All of the Public Health Council meetings are public. All of the Ad Hoc leadership group meetings are public. And so that will be a real opportunity to see how this process proceeds and to maximize the engagement of multiple stakeholders. So I encourage you to think about that. As I said, Chicanes has been involved from the beginning, family medicine, but I think there's a real opportunity now for, especially with the primary care sector, to think about the partnership between primary care and community determinants of health and make sure that these initiatives reflect that. Thank you. Yeah, I think the dashboard that I showed you is where that gets tracked. These 51 in each of their goals and objectives under each one, and there's a really interesting, especially in this alignment issue I talked about what hospitals are doing in DSRIP and reporting on Schedule H and actually supporting in their Prevention Agenda Coalition. One of the issues is alignment, the other is an evidence-based intervention. So what you have for the State Health Department dashboard are evidence-based interventions that are provided to the local authorities to say this is, if you're dealing with promoting breastfeeding, if you're dealing with promoting green space creation in your community for exercise or decreasing smoking. These are the evidence-based initiatives that are available to you that you can look at from the U.S. Preventive Services Task Force or the CDC Community Medicine Task Force. And one of these we learned the first round is that the local communities don't have the capacity to get that data. They just don't have the infrastructure. So the state has really stepped up to the plate, and this is one of these little small things, but that dashboard, which is available to everybody, you can go on the state website. It used to have a blue button, and you'd push the button and you'd get into it, and you'd see the dashboard, you'd see all the interventions, all the objectives. The blue button disappeared when they redesigned the website, so now you have to find it underneath underneath chronic fatigue syndrome or Lyme disease or something. So we're trying to get it back anyway, but it's very hard to find right now, but if you look for the prevention agenda, you can find it. But that's one of the trivial things, is just to really get that back up there, because you want it. It's a fabulous evidence base, but was created for the use of local communities and multiple stakeholders. But it is being tracked very carefully. There's some stuff, I don't remember the indicators, but if you go there, you can see the progress that's been made in the first round.
Good morning.
I understand.
One of the items in the state prevention agenda that you mentioned was promoting healthy women, infants, and children.
Yeah.
Considering that intimate partner violence is one of the leading causes of death for women of color, is there anything being done on the state level to address this issue?
I don't know. I can't answer the question about state policy. I think some communities that have chosen that as a priority are working on that issue, because the state doesn't, it's really within this frame. They decide what they're really going to work on. And I think there are some communities that are working on it. But again, we don't mandate what they choose how they're going to do it. But it's in the thinking. I think part of the really interesting questions about this intersectoral process is bringing in areas like criminal justice, like policing, into these conversations. And it's an exciting prospect in some ways, but I'm sure, I think the state does have some, I just can't remember it, I don't really know, but I think there probably are communities that it's included in their plans. And you could go online, you could see the plans, because the plans for each community are public on the website. Yeah, Verna? Maxine, sorry, I'm so sorry.
Just a comment about the FIP, the Population Health Improvement Program boards. I happen to sit on the one for Mid-Hudson from Ulster County, and they're such a good idea, but they're so under-resourced that it's almost unfair. I mean, the Mid-Hudson one has 7 counties. These are semi-rural areas, so that's a lot of geography. They have a staff of 4 people. There's no funding for any direct service. So if the staff works with a community-based group that really wants to do something, but the community group doesn't have the capacity, the FIP isn't allowed to pay for it even if they had the funds. So in your work, I just think that we need to begin to address the reality of having a 7-county area with 4 staff people.
Yeah, well, New York City is 1. So, I mean,
Oh, well, never mind.
No, I mean, there's one, I don't disagree with you. I showed that last diagram on purpose, is to make the point about where the money is, and that's part of the challenge. I think, you should call the people in Rochester. The Finger Lakes group is supposed to be the resource for the FIPS, and we've increasingly been bringing the FIPS into the Ad Hoc leadership group and trying. I mean, it was renewed. I think there was a question as to whether it was going to be renewed past the 2 years, but I agree it's under-resourced. But it's coming directly from the governor's funds. It was disallowed by the feds. It was put in the waiver, and they didn't accept it. And to the governor's credit, they put it in. So anyway, yeah.
So I have the next question.
Yeah, one in the back.
Oh, and then I'll bring you the mic. How's that? Good. So it seems to me we have 2 choices. One is we either cop to the fact that hospitals are not the center for the healthcare system, because they sit in the communities with the worst healthcare, and they don't seem to have any real sense of responsibility for the health of those communities. I mean, you don't hear hospitals talking about, gee, they all have little programs that they do little things with, but you don't hear hospital people you hear them talking about the economics, you hear them talking about their specialty services. When you walked in the door today, there were greater than life-size pictures of all the interventional cardiologists, but you don't see pictures of what's going out in the healthcare system. So you either decide that's the direction to go. We just say hospitals are what they are, which is a good thing because we need them to do what they do for that less than 1%. But don't look to them for being the resource or the center for healthcare systems that are trying to improve the health of the community. Or we have to hold them accountable, and community health centers and everybody, to really move accountability into those systems. But we can't leave it the way it is, because the way it is isn't real. So which of those 2 directions do you think we should move? Should we move towards holding institutions, and like ours, unlike the Institute and like our community health centers and communities, more responsible for paying attention to and trying to address the actual needs of those communities from a population health standpoint? Or should we just leave the delivery system as sort of outside of what we should be doing in population health?
Well, I mean, I think clearly the bubble diagrams I showed you, the healthcare delivery system is not outside those diagrams. I think they're really important actors. And I think the challenge for the state healthcare reform is trying to move the needle in the direction you're talking about. And probably the primary care providers would be more values-based oriented, but don't have the resources, and the hospitals are really beginning to think about it. But there are a couple of and I think I was discussing this with somebody from another state the other day. I mean, one of the problems is the reimbursement system in New York State is still half fee-for-service and half managed care. And if you don't have a managed care approach, there's not much of an incentive to really making the kinds of strategic transformations that everybody's telling them they should make. I mean, one of the large ACOs in this state, which is a multi-specialty physician group practice, which shall remain nameless, I mean, they are able to reduce Medicare admissions by 40%, you know, in their local hospitals, and they're not getting paid for it they're not getting rewarded for that at this point in time. So there's that schizophrenia, which I think until it is dealt with in a fundamental way, we try for Medicaid, but if the other payers are, you know, not that way, then it's pretty hard to change your systems in a fundamental way. So that is an issue that needs to be addressed. And maybe in, you know, some perverse way, some of the questioning about the ACA and, you know, focusing on savings, the states are going to have to, and if the experts are if the experiments are in the states are going to have to do something about those resources. They're not going to be an unlimited amount of resources. So how that plays out, we don't know. The other interesting concept is hospitals as anchor institutions in their communities, which really implies more of a focus on their own workforce, on the economic development opportunities they have in communities in terms of purchasing, in terms of the sort of housing stock surrounding the hospital. I mean, Montefiore got into housing stock in the 70s because they weren't going to have a community around the hospital if he didn't do it. But I mean, really looking at them in the terms of what they are, what they can do is to steer their economic opportunities and deal with the health of their workforce and other things. So that's, you know, there are multiple roles they can play, and I think you're right. I mean, it's not fair to say they're going to do all, they can't do all of that. That's why these partnerships are so important. But, you know, I think there are going to be a lot of pressures to move faster, but fundamentally this reimbursement system is a real problem. I mean, I think it's going to be interesting to see what Columbia does in their accountable care community program. I mean, to me, it's still health and social services integration, but, you know, the Brooklyn plan that's come down from the state theoretically is supposed to deal with primary care development, food deserts, et cetera. So, well, you know, it's coming, but it's slow.
Hi there. So first of all, I just wanted to say how much I appreciated the emphasis on language. I'm in social work, and I think that sometimes we forget that the language gets lost when we present specifically on financials, which are really, really interesting to see as somebody who provides direct service delivery. The other thing is, I was wondering if the slides would ever be available to us, because
Sure.
I think that it is
Absolutely.
so wonderful. Because I think that somebody who's coming from a preventable admissions background, it's so good to see what the ROI on our work is. So that, and also how can we as direct service delivery individuals have a broader conversation about the, you know, the necessary financial needs that we face, giving those services, transportation, food deserts, you know, when we're trying to put those things into place and we're just finding kind of a, not so much of a wealth of resources out there, how can we really engage our local lawmakers, different institutions into having more of a conversation?
Yeah, it's an interesting question. Part of what I mean, I'm always an optimist. You have to be an optimist when you're in primary care, right? But I think this conversation about health across all and also the age-friendly work is very interesting because it really, older people need, you know, they are disproportionately represented often in the health home populations, in the populations of the complex and costly patients. That's not 100% true, and we're trying to keep them from being in that situation with age-friendly, but I think that's just the reality. And if you begin to look at the environments which keep older people active and engaged, it is these support services that you're talking about, and it's also dealing with how do you create situations where they're willing to come out of their homes and go do their own shopping because they have a place to sit between their home. And I mean, it's very fundamental stuff, you know, and I think people begin, to me, I was at a meeting at this 2-day summit that AARP had up in Albany yesterday on the age-friendly component of this statewide plan that the governor's articulated. And I think they had urban planners there, they had transportation people there, they had housing people there. They've been in conversations for a decade or more about this, and they are just thrilled to see this come up. And I think those of us in the broader population health interest group and primary care interest group could ride on those coattails to some degree, because it doesn't really matter how the community change occurs. We just want it to occur. So, and the other thing is I think the Bradley evidence base is really beginning to get some legs, those buckets of services that I talked about. At CMS, we have a colleague, when Neil introduced me, he mentioned the Health and Society Scholars Program, Don Alley, who is one of the Health and Society Scholars, postdocs, is in CMMI, the Innovation Center, and she's an social epidemiologist by training. And we've had long conversations with her about the evidence base for having CMMI agree to pay for something. So this is a big deal that they put this RFA out, including these social services. It may not be, we're calling broader determinants of health, but it's a start because the evidence base is really, really rigorous. So the Bradley work has been really important in making that possible. So I think you want to keep your eye on that. The state is looking at some regulatory modernization agenda now, and we know that there are regulations that are blocking integration of behavioral health in primary care. There's a lot in play, but I think Chicanes has historically really been honest on this stuff, big time. Family physicians have sort of been in and out. I don't know who's the head of the statewide agency at this point in time, but social work, I don't know about the state social work group. They haven't shown up. The nurses and the docs are there, so you might start there.
Thanks, Joe. I think you want to ask one more question? Go ahead, say it, and then I'll announce it.
Just FYI, all of the grand rounds are archived on the Institute's website. They're a little tough to find right now. They're under residencies.
It took away your blue button. Yeah,
moving them. We're trying to move them further forward on the website, but they are there, and this one will be there in about a week. It takes about a week to post.
The Ellis, thanks, Joe, this is great. The Ellis story is really fascinating. I'm wondering if in this discussion there are newer structures, community structures, because what you're describing are dialogues among different stakeholders that don't normally happen.
Yeah.
And I'm just wondering about the sustainability of something like this, where a community could take on, let's say, this group of people in end-stage renal disease and say, well, what's the next group that we want to deal with? And how do people envision this being a sustainable model for change?
Well, it's interesting. I mean, I think, it's a good question because it's not being funded directly by government, but I think the Ellis example is, so I wanted to say this earlier, but I'm going to say it now because you gave me the opening. When you're in New York City, none of this stuff makes sense, right? I mean, you hear it and you think, okay, pie in the sky. When you're outside New York City, and you guys are, I mean, and everybody kind of watches what you guys are doing in the Hudson Valley, and it's one of those regions of the state that's really important. And so, if I'm saying, where am I going to put my focus and my energy, I'd say, let's think about how that you can put your forces behind the FIP, behind the prevention agenda platform that exists, et cetera, et cetera. And I think that's really important. And I've been up to Fort Drum, presenting the prevention agenda at 8 o'clock in the morning to 300 people, because there's 7 counties who work together up there. Every hospital CEO was there. A representative from each assemblyman's office was there. And they were there to unveil the website that was going to show how they were doing on the dashboard for the prevention agenda. I mean, that's the real world. We don't live in the real world. I mean, we live in our world and we have to deal with it, but don't be discouraged by that part of it. I think it's really important. So the sustainability, the way they describe it, they have come together to write for grants, which they all agree they would never have gotten if they weren't a partnership. Ellis is beginning to re-steer its community benefit investment in that direction because they're on the record now to do it. And, I think it's really, when you see Syracuse and the Maxwell School has been really involved with this big grocery store there that has put, information sources, sort of like the doc, not a doc yet, but I mean, nurse practitioner is in the grocery store giving people health information about purchasing healthy food. So, there's legs. People have to own it ultimately. We have not, part of what we're hoping in this new round is to get some of this economic development money directed in this area because it's local money, and connecting these REDICs with the platforms, getting some of the money from the Department of State, from transportation, from housing into these communities because they have targets. They're doing stuff, and if you think about how do you connect up with the health professionals, so I think the thing is home grow it. Anything that's dependent on outside money is tough right now. There you go. Well, bring out the governor's thing and go for it and let us know about it. Keep us posted because that's a real opportunity. So
Thank you very
yeah.
much.